the impact on utilization. The intention of the Affordable Care Act, or ACA, was to expand coverage through two mechanisms. First, people with moderate incomes could gain coverage through the exchanges, often encouraged by subsidies. And two, those with lower incomes could gain coverage through an expansion of Medicaid eligibility to include groups that had not traditionally qualified for Medicaid. The results, however, have not been aligned with the mission. 32 million people expected to gain coverage, but this has not happened, only about half that. There has been a Medicaid increase, however. The ACA coverage expansion appears to be widening a pre-existing gap between states that have elected to pursue Medicaid expansion and those that have not. Providers in the Medicaid expansion states have already started seeing higher proportions of Medicaid beneficiaries in 2013. Chronic disease was supposed to be an increase from the ACA with new patients, but statistics have not reflected this. Hospital admissions also were supposed to drop from these same chronic ill patients as their treatment plans were more widespread and encompassing, but this too has also not been validated.
Prior to the implementation of the Affordable Care Act, various states had adopted systems that mimicked the guidelines and infrastructure of the reformed healthcare system, Massachusetts and Oregon being two of them. Brent Kell, the CEO of an urgent care practice in Oregon, has offered some insight into how the Affordable Care Act has affected providers in various specialties.
Value immediate care, we've already seen an impact of the Affordable Care Act. Obviously, with more people who have insurance, there's going to be more people that are not waiting on those aches and pains and colds and sore throats and are seeing us much more rapidly. The problem we see in the future going forward is that both state and federal healthcare initiatives have been aimed at health insurance, and the assumption has been made that the lack of health insurance has been the big barrier to receiving health care in the state and the country. And piece of that is very true. However, once you provide the general population with health insurance, then we face another stricture, and that's the number of docs available.
In order for the Affordable Care Act to be successful, healthcare professionals have to understand the impact it will make as well as the changes that will occur. The below sample of a brief survey that I conducted clearly shows that healthcare professionals across the board are unsure of the effects of the Affordable Care Act. Successful implementation of the Affordable Care Act will need to make education a priority. Professionals in the healthcare field are being forced to make multiple changes in their documentation and treatment patterns. There's an overall understanding that these changes must occur in order to collect reimbursement. However, the underlying reasons for the changes are still not fully understood. Physicians are going to become more and more frustrated with the changes until they are educated on why the changes are occurring.
The ACA impact on private versus corporate-owned practices. Let's examine the ACA's impact on the private practice. It's determined that solo practices will become extinct. The ACA will encourage private practice models to consolidate under corporate models. Enhanced compliant obligations cannot be sustained by private practice models. The ACA will encourage seeing more patients at less cost. New models will emerge that are primary care based.
With one of the main goals of the Affordable Care Act being to provide affordable health care to more people, there will be a huge increase in the insured population. An estimated 30 million are expected to gain health insurance in the near future. An expansion in coverage, however, does not necessarily mean an expansion of care. The healthcare field has been short-staffed for decades. An increase in the insured population nationwide will only highlight the shortcomings of an inadequate number of healthcare professionals in the field. Patients will experience longer wait times and less access to their providers, therefore less access to efficient care. The model demonstrates the equilibrium between the amount of healthcare that is delivered and the cost of that care. An increase in the demand of medical care will cause the demand curve to shift to the right. If the number of providers in the field does not increase, then the cost of care will be more for the patient. The only way to keep the cost of care for the patient low while not increasing the number of providers is to increase efficiency of those providers. Increasing efficiency of the providers will allow for an increase in demand of medical care, but the cost of medical care will remain constant. Currently, only 1/3 of all medical providers are primary care providers. The additional 2/3 practicing some sort of axillary care. In order to keep up with the increase in the insured population due to the Affordable Care Act, there would need to be an additional 8,000 primary care providers introduced into the system each year. Primary care providers are being forced to act as gatekeepers to axillary care providers in order to treat all the newly insured. As gatekeepers, primary care providers will perform a large amount of triage and basic medical care, but will lack the time for expansive diagnostics and treatment. Currently, there are multiple barriers to primary care. There's an estimated $3.5 million gap in coverage between primary care physicians and specialists over the course of a career. Reimbursement for primary care providers would need to increase by $100,000 a year in order to reach the average income of a specialist provider. Also, most medical training occurs inside a hospital setting. Most medical residencies done in a hospital setting are done with axillary care providers rather than primary care providers. Medical students tend to find their role models and mentors during those residency programs and lean towards practicing his or her specialty rather than primary care. Governmental insurances, Medicare and Medicaid, have developed incentives for primary care providers. Not only are they increasing reimbursement rates an average of 10% for services that are typically performed by primary care providers, but they are also promoting coordination of care reimbursement options. The Affordable Care Act will increase grants and loans and repayment options for medical students that agree to practice primary care. There is also an increase in the number of government-funded residency programs that focus solely on primary care. The Affordable Care Act will invest $230 million in the next year to increase the number of medical residents that choose to practice primary care rather than some type of axillary care. By the end of the 2015 fiscal year, there will be an expected 1,700 new providers in the field nationwide. There will be an additional $50 million a year invested to train nurse practitioners and other mid-level providers in primary care services. The incentives that the government is implementing will in hopes be successful in keeping the cost of medical care low for patients as the demand increases. We already saw that there will be an increase in demand for medical care as the number of insured increases. This model demonstrates that the supply of medical care can increase by increasing the efficiency of providers. If the efficiency increases, the same number of providers in the field can treat more patients at the same low cost to the patient.
While the Affordable Care Act presents incentives for primary care providers, specialists are concerned that they are going to experience adverse reactions to the additional funding provided to those primary care providers and some identified subspecialties. As the number of patients requiring specialty visits is projected to grow, significant impact may be felt by specialists with expensive services that are offered to patients with high deductible and Medicaid policies. With an increase in the number of patients with insurance, utilization of primary care physicians eventually will increase, thus theoretically leading to an increase in the number of specialist referrals generated. The PPF demonstrates the source of the specialist providers' fears, that the increase in funding for primary care providers and specific subspecialties will inherently decrease the monies available to the rest of the providers. The subspecialties that are to receive additional funding for practice and recruitment include pediatrics, mental health, and surgical services. All of these specialties have been identified as being in deficit. For example, 84% of emergency department providers explain that mental health patients are boarded in emergency departments due to the shortage of specialists in that area. The additional funding provided to these specialties will, in theory, provide additional access to care and help providers manage the patients needing those services. But how will we effectively manage patients seeking other specialty care that now have either Medicaid products or high-deductible insurance policies? By better utilizing mid-level healthcare providers and specialty practices. This change will increase the supply of care offered to patients at a more reasonable price. The shift in paradigm will help practices better control costs and make care more affordable and accessible for patients. In addition to specialties managing more patients, other providers may feel some initial pressure from the Affordable Care Act as well. If all goes to plan, primary care providers will be able to fill the gaps when it comes to episodic care, as well as the management of chronic conditions. There are problems that lie, however, in the fact that the funding and recruitment process is ongoing and has not come to fruition yet. The existing volume of primary care providers simply cannot accommodate the substantially growing insured population until recruitment has been effective. So what happens now? Brent Kell, the CEO of Valley Immediate Care in Medford, Oregon, describes the importance of the providers who are currently bridging the gap until there are sufficient primary care and specialty providers available to patients.
With those issues in mind, we have to, our system has to provide some alternatives for patients that have episodic need for care, for illness or injury. If primary care is going to take you 4 to 6 or 8 weeks to get an appointment for that sore throat, sprained ankle, possible broken finger, cut on the knee, all those types of things are not going to wait for a primary care appointment. And so we have to provide urgent care or intermediate care or fast track, as the hospitals call it, to accommodate those needs. If we do not do this, then all those episodic illnesses or injuries will end up in the emergency room, and that's going to bankrupt the system.
When evaluating the effect of the Affordable Care Act on urgent care and emergency care providers, there are 2 factors to consider: short-term and long-term effects. In the short term, emergency department and urgent care providers are seeing significant increases in the volume of patients presenting for treatment of chronic and episodic care. This is part due to the expansion of Medicaid programs in some states, combined with a shortage of primary care providers that are able to manage the chronic and episodic conditions that the Affordable Care Act has been expected to help with. The model describes the conditions, increasing the price of medical care as quantity increases. Demand then becomes even more inelastic in the areas with expanded Medicaid programs where more patients have reduced out-of-pocket expenses. Increases in emergency department visits also puts pressure on specialists who are on call to see the patients in the emergency departments. Urgent care providers are also reporting increases in patient volumes due to long wait times to see primary care providers, as well as after-hours services that are now covered by expanded Medicaid insurance policies. 35% of emergency department providers state that they are now having to see more Medicaid patients in their emergency departments than before. If the Affordable Care Act's goals of provider recruitment are sustained and accurate, patients will eventually have more access to affordable care through primary care providers. The assumption then leads that chronic conditions will be detected earlier and managed better by those primary care providers, thus reducing the pressure on specialist, emergency, and urgent care medical providers. A 2013 survey reports that, long-term, 34% of medical providers feel that the Affordable Care Act, if executed as planned, will eventually help decrease emergency department visits and costs.
The ACA impact on providers: a decline in productivity. A shift to corporate practices typically will mean physician productivity decline. Improved productivity is key to a long-term resolution. This will lead to reduction in patient care. Let's examine a market model on this. Let's examine a market model of decline in productivity. If we look at the market model for medical care, we see the normal demand and supply noted as lines D and S. While many physicians who make the transition to employment by hospitals and large medical groups benefit because they no longer have to deal with administrative and staff issues, they also frequently become less productive compared to their private practice counterparts. In fact, Scott Gottlieb, MD, writing in the Wall Street Journal, concurs. He fears that by incentivizing the delivery of outpatient care through hospital-owned networks, the ACA will directly lead to a reduction in physician productivity and also a loss of quality in care. He says industry estimates show that productivity falls by 25% or more for physicians who work for hospitals or hospital-owned groups. This is a consequence of the more fragmented, less accountable care that results from these schemes, he says. I've seen this drop in productivity in several organizations with whom I have worked in the past as well. This drop in productivity will cause a shift in the supply curve noted by line S1. This will result in less patients seen and will raise the cost of medical care as corporate practices still try and meet their budget with fewer patient visits. Productivity, then, is the key. Well, why should we all be concerned about this? Well, because the only way we're going to solve our long-term fiscal challenges when it comes to programs like Medicare and Medicaid is to improve productivity so that we can get more health care for every dollar of GDP that we spend on it. Patient volume is expected to increase, yet provider volumes are expected to decline. Corporate-run practices have key bargaining power, but studies show that this market concentration or monopoly markets lead to higher health care costs, which is exactly the opposite of the ACA objectives. There will be a reduction in patient care. Finally, this transition from doctor as entrepreneur to doctor as employee will only accelerate as the ACA is fully implemented, which is bad news for patients because reduced physician productivity translates into reduced access to care. Seeing more patients at reduced cost. Physicians will be required to see more patients at a reduced cost, or more for less. To see more patients and still trim costs will put more stress on providers. This will cause some providers to consider new employment where they receive help. Some, however, will consider getting out of medicine altogether, which will only help to increase the already predicted physician shortage. If providers are put under the microscope all day, they will eventually ask themselves, why am I doing this? I am smart. I can do other things with my life. Compliance mandated by the ACA will increase. Reform will drastically increase physician legal compliance obligations and potentially liability under federal fraud and abuse statutes. Enhanced funding for enforcement, additional latitude for whistleblowers, and the suspension of the government's need to prove intent will create a compliance environment many physicians will find problematic. Again, with limited monetary resources and expertise in compliance programs, private practice programs are at a disadvantage and will need to join forces with more knowledgeable colleagues who can all contribute together toward a single compliance program, sharing in its expenses. The risk is too great for a private practice to not have a detailed compliance program, and the best answer is for them to secure their future with sharing or a single compliance program among a large organization. The ACA is pushing toward consolidation to a corporate model. EMRs will be mandated to take advantage of incentives. EMRs are expensive, however, to implement, and their cost is easier to spread out among physicians. Capital will be required to maintain EMRs and reporting. Additional staffing will be needed. The question is, where will the staffing come from? Administrative resources will be necessary to keep up with reporting requirements. Technical resources to gather, organize, and report data will be required. These extra costs will be more easily controlled by corporate practices. Private practices are generally more lean in their resources, with each one already stretched beyond capacity. Reimbursement will change, favoring hospitals' outpatient procedures that will be better compensated when they are performed in hospital-owned practices versus independently owned practices. All of these elements have the predictable effect of driving consolidation of medical practices around the hospitals. This is going to raise healthcare costs and lower productivity across the medical marketplace. This will not meet the ACA projections, but instead have the complete opposite effect.
The electronic medical record, or the EMR mandate under the guidance of the Office of the National Coordinator, part of the American Recovery and Reinvestment Act of 2009, authorized the Centers for Medicare and Medicaid Services to award incentive payments to eligible professionals who demonstrated meaningful use of a certified electronic medical record. These providers had to participate early in the grant in the years 2011 or 2012 in order to receive the maximum incentive. And the participants must prove meaningful use of the patient data. This means that they must follow the different stages that was coming out, stage 1, stage 2, and they had to keep up with these mandates of the meaningful use in order to continue receiving their incentives. In North Carolina, the Regional Extension Center was responsible for assisting implementation of the EMR and establishing who met the criteria to receive the incentive. They had to use certified EMR technologies that comply with the security rule of HIPAA. The reimbursement penalties for not implementing the EMR in the year 2015 is 1% the first year, with increments up to 5% in forthcoming years. At the end of 2011, many physician offices were not taking advantage of the EMR incentive. Most were reluctant to change. Older physicians were not comfortable with new computer technology such as tablets and smartphones. Others were worried about the extra expense in years to come. 60% of physicians were part of a large healthcare group, and 40% were struggling to be sole or partial owner of their practice. This changed the pathway for upcoming physicians while they were making decisions in school. They wanted the security of a large practice, but they did not want to deal with new laws, regulations of operating a sole or being part of a proprietorship. 56% of new physician graduates sought positions in hospitals or large healthcare facility practice. This was an increase of 23% over previous years. The major reason of the shift of the physicians merging from larger groups is the expense of the implementation of the EMR. Sole or partnerships would have to increase their patient base in order to bring in more revenue to exist. And this was due to the implementation of the EMR, and they had to be prepared for the upcoming technology, and there was no other way to do this unless they increased their patient base. Dollars spent on the EMR PPF. If we look at the dollars spent on the EMR in a production possibility frontier model, we can agree that there are limited dollars within any practice and fewer in a privately owned practice. The models, the more dollars spent on the EMR means there are less dollars able to be spent on areas such as salaries, benefits, and equipment. The less dollars available for an EMR due to limited funds and other constraints normally experienced in a solo practice means less dollars toward an EMR. The Central Utah Multi-Specialty Clinic consists of 59 physicians in 9 locations. They are averaging 20,000 additional charts per year. The additional charts are to afford implementation of the EMR, plus the extra marketing dollars due to being a large practice. Their expenses include the initial costs of the EMR, which was around $300,000. It also includes cost of future updates, vendor support, and future technology. You have to keep in mind when it's not just the implementation of the EMR, you have got to maintain that and keep that flow of data continuous. This may take teams of project managers having to analyze the data flow. So you have expenses of that, and it's not really, you really have to plan when you're going to implement the EMR and really budget your dollars to make sure that you are able to handle the EMR, plus get the most use out of the EMR that you select. The Central Utah Multi-Specialty Clinic savings included additional space for clinical use since the paper medical records were eliminated. They also saved on supplies of the paper record, which included the actual folder and the labeling and the system to track the charts. The patient volume increased without no FTE due to the efficiency of the EMR, and there was also lower transcription expenses since it was built into the EMR, and there was increased revenue due to improved EM coding. The EMR implementation and physician productivity was time taken away from the patient. Physicians were spending more time on the computer than talking directly to the patient, creating a new job, medical scriber, who follows the physician around and are in charge of inputting what the doctor is saying, and they are doing this live into the computer as the physician is seeing the patient. This improves clinical productivity and patient satisfaction, but it has impacted the cost of the health care. It's because you need another full-time or part-time person to be able to follow the physician around and capture the data that's being presented.
In summary, the ACA will cause privately owned practices to go the way of the dinosaur. This will force private practices to consolidate and/or solo providers to join corporate models. New practice models will emerge in order to become more efficient and compete for new payment and incentive arrangements. As providers consolidate and/or join corporate models, their productivity will decline. This will cause a decline in the delivery of medical care at the expense of the patient. The data collected in EMRs and how efficiently an EMR is utilized will be critical for additional payments and incentives offered by the ACA. Overall, there will be opportunity costs associated with the rollout of the ACA. Each decision will have its own consequences, no different than if we choose to eat 1 pint of strawberries or 3. After all, in economics, every decision in life has an opportunity cost.